So TAVR has been a success story all over. It has evolved from the high risk down to the low risk patients now, and it's a valid treatment option across all surgical risk spectrums. So having said that, the results of the landmark trials may not apply to all the commercially available TAVR systems out there on the market, and therefore head-to-head trials are needed. There are not many head-to-head trials performed up to now. There's been the CHOICE, the REPRIEVE 3, and also the SOLVE TAVI trial presented here last year. And for this reason, we performed a head-to-head TAVR trial assessing the ACURATE Neo device, a self-expanding supraannular valve, and compared it to the SAPIEN 3, a balloon expandable intraannular device, which has been investigated extensively in the PARTNER 2 registry and also in the PARTNER 3 trial, and which has shown excellent outcomes with regard to early safety and clinical efficacy, and therefore can be regarded like as the benchmark. So what we did, we randomized 739 patients undergoing transfemoral TAVR to either the ACURATE Neo device or the SAPIEN 3. We had a mean age in our cohort around 83 years. 57% of the patients were female, and the median STS score was 3.5. So over 90% of our patients were actually in the low or intermediate risk categories. The primary endpoint, which was tested for non-inferiority at 30 days, was composed of all-cause mortality, of stroke, of life-threatening bleeding, major vascular complication, coronary artery obstruction requiring intervention, rehospitalization for valve-related dysfunction, congestive heart failure, also repeat intervention, and importantly, an echocardiographic component, valve-related dysfunction comprising measures of valve stenosis and also moderate or severe paravalvular regurgitation. We had an echo core lab to assess all echocardiographies, and we had an independent education committee looking at all the clinical events. And the follow-up rate was very high, with 99% for clinical endpoints, 98% for the echoes. So a good setting for non-inferiority trial. So as opposed to our study hypothesis was non-inferiority of the ACURATE Neo versus SAPIEN 3, we actually found that non-inferiority was not met for the valve. It was due to a risk difference of 7.1% in favor of the SAPIEN 3 device, and the upper limit, the upper 95% confidence interval limit, was at 12.1%. So it clearly crossed the pre-specified margin, which was set at 7.7%. In secondary analysis, it was even shown that the SAPIEN 3 was superior to the ACURATE Neo with regard to the primary endpoint. And when looking at the individual endpoint component, it emerged that it was driven by acute kidney injury and, importantly, by a higher rate of paravalvular regurgitation in the moderate to severe degree range. So these were the driving forces for the difference in the primary endpoint. Regarding secondary endpoints of importance, there was no difference between the two valves with regard to pacemaker rates. It was 11.5 versus 10.3%. Overall clinical event rates were actually pretty low, and with the ACURATE Neo we observed lower rates of transvalvular gradients and correspondingly higher effective orifice area, which can be attributed to the supraannular design of the valve. So these were the major findings of this trial. The stroke rates, they were 3 and 2%. I think concerning the primary endpoint results and specifically the higher rate of paravalvular regurgitation, which has been shown to be the shortcoming of this device, there are several things that have to be looked at. Specifically, we have to look at whether there are certain patients or patient characteristics with regard to anatomy, to calcification distribution in the landing zone, which predispose these patients to a higher risk with the ACURATE Neo for developing moderate or severe regurgitation. For this, we will have to look into the CTs more closely, and we will do that in a centralized analysis, and then we will see whether there's an impact with this regard. The next step is also to have a look at the long-term outcomes or mid-term outcomes in 1 year, and it will be important to see whether these higher rates of paravalvular regurgitation actually translates into clinical endpoints like rehospitalization, reintervention, or even mortality, as shown in other trials where moderate or severe AR was associated with these endpoints. So that'll be important steps with this regard. Concerning the valve itself, there's a reiteration of the ACURATE Neo device, the ACURATE Neo 2, coming on the market in Europe soon and being evaluated in the US ID trial currently and last till next year. And it'll be important to see whether measures that have been taken with this iteration, there were refinements with regard to the sealing skirt. So they're actually addressing the shortcoming of the current iteration with the new device already. And it would be important to see the outcomes of these trials to see whether they were able to reduce the paravalvular leakage rates.